hypermetropia. So we will just take the hypermetropia, which will be the reverse of myopia, and then we will take a break to continue our second lecture. So what is the hypermetropia? The hypermetropia, it is a refractive condition in which the incident parallel light rays come to a focus behind the retina, while the accommodation is at rest. And here the accommodation plays an important role, that as we will discuss later on. So if we have here an eye and the parallel light rays will not come to a focus into the retina, but will come to a focus behind the retina, because the eye either it is too weak to converge the light rays over the retina, or it is too short so that the light rays will come to a focus behind the retina. And this will lead to that these patients will not be able to see the near targets. So if the patient can see the distant target clear as here and there, but while they are reading a book, they cannot see clearly. So this is the sight of a patient who have normal vision, and this is the sight of a patient who has hypermetropia. They cannot see the near target clearly, but they can see the distant target clearly. Again, this is another illustration for the hypermetropia. So if we are reading a newspaper and behind we have this scene, so the newspaper itself will focus, or will reach to a focus behind the retina. That's why it appears blurred, while the scene itself fall as it is from distance, it will come to a focus into the retina, so it will be appear more clear. So what are the optical principles of hypermetropia? So if we have a parallel light rays coming from an object present in front of the eye, they will form a circle of least confusion. So this is the emmetropic eye, and this will be, sorry, this will be the circle of a larger of circle of least confusion will be made on the retina. So this should be the focus of the normal eye. And since that the eye light rays, the image size will be on in the emmetropic eye will be normal, but in case of hypermetropia, the image size will be smaller. So let's make another illustration for it. So here we have the hypermetropic eye, which is a smaller eye that form a focus behind the eye like this. So the eye itself doesn't form a focus into the retina, but it form a circle of confusion. So that because that the eye doesn't have a sharp focus over the retina, it will be formed by the light rays that are converging to form a circle of confusion into the retina. And since that the retinal image size is smaller in the uncorrected hypermetropia than the emmetropia. So we said that in case of myopia, the retinal image size will be larger, and the reverse will be in case of hypermetropia. If we have uncorrected hypermetropia, so the eye itself acts as a magnifying lens. So since if the power of the eye is smaller in hypermetropia, so the magnification will be smaller. So the eye will show smaller high image size in case of uncorrected hypermetropia. However, if it is corrected, as we said in the myopia, and the object is present, or the glasses is present in the f1, then the retinal image size will be unchanged. Again, let's make this more clear. If we have uncorrected myopia, the retinal image size will be larger. If we have uncorrected hypermetropia, the retinal image size will be smaller. If both of them are corrected and the correction is present at the f1, then the retinal image size will be the same. And this is what's called Knapp's rule. So Knapp's rule mentioned that if we have an emmetropic eye And this ametropic eye is ametropic because of axial myopia or axial hypermetropia. So the eye is either short or either long. And we need to correct this eye. And by correction of this eye with a lens present at the FA or the anterior focal point, or F1, it is the same thing, the magnification of the retinal image size will be the same as the emmetropic eye. This is very, very important, because if we place the image or we place the lens either inside the FA or outside the FA, then the retinal image size will be the different. As we said, the myopic patient tend to push his glasses toward his eyes to gain more magnifying effect, because the lens is not present at the FA. And this rules only applies for the axial eyes or axially ametropic eyes, not all eyes. So, what are the optical principles of hypermetropia? The light rays emerging from a point on the retina will emerge divergent so that they meet a point behind the eye, which is the far point or the punctum remotum. So here the F2 lies behind the retina. As you can see here, the light rays enter the eye. The eye, either it is too short or it is too weak to converge the light rays, so that the F2 is not present on the retina, as in case of emmetropia, and or not in the vitreous, as in case of myopia, but it is present behind the eye. Behind the eye, so it will be the F2 is located behind the eye. So where is punctum remotum? We need to know where is punctum remotum, or the distant point, in order to know how to correct or optically correct this eye. The punctum remotum here is not a true point in front of the eye as in case of myopia, but it is a virtual point behind the retina. Let's see how is this. As we mentioned before, if we have light rays emerging from of the retina in case of emmetropia, they will enter into the optical system of the eye and they will emerge parallel, so that they will be the punctum remotum of emmetropic eye will be at the infinity. In case of hypermetropia, if we have a point or a point emerging from the retina in case of hypermetropia, and then the light rays emerging from this retina will be divergent, and when it comes to the optical system of the eye either it is too weak or the eye is too short. That's why the light ray emerging from this hypermetropic system will be divergent. So it will not be convergent as in case of myopia, and it will not be parallel as in case of emmetropia, but it will be divergent. So these divergent rays will make a focus, but this focus is not true. It is virtual, and it is behind the eye. And this virtual focus will be called the punctum remotum. So punctum remotum in hypermetropia, it is a virtual point behind the eye that is formed by the extension of divergent light rays emerging from the eye. And here is the punctum remotum of the myopic eye. So in myopia, the punctum remotum is a real point in front of the eye, while in the hypermetropia, the punctum remotum is a virtual point behind the eye, and the punctum remotum and the F2 are called the conjugate points. And what do we mean by conjugate points? This means that if a light ray enter from the F2, it will reach the punctum remotum, and if a light ray is entering from a point at the punctum remotum, it will reach the F2. So the same thing applies for hypermetropia. If light rays emerging from a point at the F2 will be divergent, and their extension will meet at a point at the punctum remotum. And if we have a point, or if we have an object placed at the punctum remotum, and it will emerge light rays, they will enter in the system, and they will enter will enter through the system, and they will be emerge as divergent, as we can see here, so that they will meet at a point on the retina, at a real point on the retina called the F2. So punctum remotum and F2, both of them leads to each other. And again, in emmetropia, if we have a point at the F2, will emerge light rays that will emerge from the eye parallel. And if we have parallel light rays coming from the punctum remotum, they will come to a focus in the F2. So F2 and punctum remotum are conjugate points. Dr. Shadi says that in hypermetropia, we cannot see the far and the near good. This depends on the amount of hypermetropia. So in early cases of hypermetropia, where the accommodation can compensate for the hypermetropia, as in case of children and young adults, then this will using their accommodation in order to see the near targets clearly. But they will not be they can see the near targets. However, as they get older and the accommodation gets weaker, they cannot compensate for hypermetropia, and they will not be, first cannot see the near targets, and as they get older and older, they cannot see the near targets and the older and the far targets as well. So this depends mainly on the age and on the amount of refractive error. So what are the different types of hypermetropia? The first type of hypermetropia will be the axial hypermetropia, which is the first simple one, in which we have the small refractive error, and this or a small axial length of the eye. That's why the light rays will come to a focus behind the eye. While in there is another type which is called the refractive hypermetropia, in which there is curvature hypermetropia, like for example what's called cornea plana. In cornea plana, the cornea become more plane or more flat in configuration. This will lead to a decrease of the refractive power of the eye, leading to hypermetropia. Or there is index hypermetropia, in which there is decreasing the refractive indices of the refracting surfaces of the eye. Or it can be due to posterior lens dislocation, or sometimes it can be due to aphakia. So there will be a loss of one major element of refracting surfaces of the eye, which is the lens, leading to severe hypermetropia. So what are the symptoms that the patient will complain from? As I just was mentioning, that the patient will complain from blurred vision for near work. So the patient will having a problem with the near work, because that he can see the object from distance clearly, because the distant object or the distant targets will emit parallel light rays. So they will enter the eyes, and the light rays will come to a focus into the retina. But the near target, the light rays will be emitting divergent. So let me just illustrate this in a simple diagram, so that Dr. Shadi Salama will have a better idea of what is meant by hypermetropia. So if we have an eye like this, as a general principle, if any light source will emit light rays at a distance from more than 6 meters, the light rays will be coming to the eye parallel. So they reach the eye parallel. So if the patient has hypermetropia and they can still have some accommodation that can compensate and they can converge these parallel light rays, they can come to a focus into the retina. This will not be the same condition as if we have a near target. If we have a near target like this flower, the light rays from this flower will not come parallel like this, because it is at a closer distance than 6 meters, but it will be divergent. So it will enter the light eye divergent. So it will need more power to converge these divergent rays in order to place these divergent rays over the retina. If the eye is emmetrope or if the eye is myope, then we will have no problem. But if the eye is hypermetrope, then the eye either it is too short or it is too weak in order to converge these light rays to be placed in front of the retina. So these light rays will be converged or will meet to a point behind the retina. So the patient will start to complain from the problems with close work. Is it clear, Dr. Shadi? Okay. So is this will be the same condition for all patients? The answer is no, because we have many variables. The first of all will be the first and the foremost important is the age of patient. We know while we are born with severe hypermetropia. The eye, the axial length of the eye is very short, about 16 or 17 millimeters. So in order to compensate for this refractive error, we have large amount of accommodation, maybe up to 20 diopters. And as we grow older, there will be a compensatory mechanism. So the axial length of the eye increase and the power of the lens decrease, so that they both compensate for each other in order to assure a smooth and good transition between the hypermetropia to the emmetropia. Sometimes there are patients who remains hypermetropic, so the eye didn't reach the actual size, or they have pathology, like as I said, the cornea plana or the posterior lens dislocation. So in such conditions, the eye cannot focus the light rays into the retina, but the light rays will become to a focus behind the retina. So as long as the patient accommodation can tolerate this hypermetropia, the patient will not be complaining. So he can see the near target and he can see the far target and doesn't have any problem. But as the patient gets older, or if the patient has large refractive error, like more hypermetropia, then more than his accommodation can compensate, then this patient will start from complaining. So, there are wide variations of presentation in hypermetropia. Either a patient can be asymptomatic, or he present with athenopia due to constant strain on his ciliary muscle due to constant strain on accommodation. So, or can have defective vision with athenopia, so he cannot see the near target initially, then the near target and the far targets, or he can have only defective vision and he doesn't have a problem with his eye strain. So what are the signs? The visual acuity is defective and it is usually more for near than in far. The eyeball can be small in size or normal in size. The cornea can be smaller or normal, and sometimes can be show what's called cornea plana or flat cornea that will lead to curvature or hypermetropia. Well, Dr. Magid asked about correction. Is it better to make a correction or when he has a complication? Well, we tend to correct the hypermetropic when the patient is symptomatic. So if he is symptomatic, no symptoms, it means that no correction. So if he is symptomatic, we do correction, and these symptoms can be either the hypermetropia can lead to ocular athenopia or can lead to defective vision. In such condition, we can give the patient the highest plus he can tolerate. And if the patient has a convergent squint in association with the hypermetropia, this can be managed by full correction. So we don't give the highest plus correction, but we give the full plus correction. This is just very simply to conclude this hypermetropia issue, but it has more details which is beyond the scope of this lecture. The cornea, the anterior chamber can be shallow and the lens can be dislocated backward, as you can see here. So here is the lens, the posterior dislocation, and the A-scan or the biometry can show the short axial length. When we're checking the fundus, we said that in the myopia there could be some fundus changes or degenerative fundus changes, but in case of hypermetropia, we can see that since the eye is small and the vessels are crowded, this can give the appearance of pseudopapilledema or appearance of like a tilted disc or a hypermetropic small disc with crowding of the blood vessels that can sometimes give the perception of presence of disc swelling, but this is rather than a pseudo swelling rather than a true swelling. The macula can be situated away from the disc. So as we said, this will lead to apparent divergent squint because the macula is away from the optic disc, leading to large angle alpha or positive angle alpha. So hypermetropia can leading to apparent divergent squint or true convergent squint, which is the reverse from the myopia. So since the myopia can give apparent convergent squint due to small angle alpha and true divergent squint due to lack of accommodation. The reverse occur in hypermetropia. There will be apparent divergent squint due to large angle alpha, and there will be true or can be true convergent squint due to excessive accommodation, as we can see. I will show. I think there will be another slide for the convergent squint. I will see you, or I will show you later. The complications of hypermetropia that it can lead to accommodative convergent squint due to excessive use of accommodation, so that the excessive use of accommodation will lead to excessive use of convergence, and this will lead to convergent accommodative squint. Amblyopia, which can be either anisometropic or strabismic or due to bilateral hypermetropia. So the amblyopia meaning that there will be defective vision in one eye with absence of organic lesion inside the eye, but this term has changed a little the last few years, but we don't need to go through this so amblyopia just meaning that there is a lazy eye that cannot see, and this can be due to anisometropia, meaning that there is a refractive difference in refractive error between both eyes. So one eye has a good vision and the other will has a poor vision, so the brain tend to neglect the vision from the poor eye. Or strabismic, so if the eye has a convergent squint, then this eye has a strabismus, and now the image on this eye will not fall on the fovea, so this will lead to lack of foveal stimulation of this eye, leading to lack of brain stimulation. Or if both eyes have high hypermetropia, then this will lead to amblyopia in both eyes, so both eyes will have poor vision, and the brain will have poor visual construction from both eyes, leading to an amblyopia of both eyes. Also, since these eyes have very small diameter and have anti-axial length and have small anterior chamber depth, they are prone to develop a shallow anterior angle closure glaucoma. And that's why we should take caution while putting mydriatics over this eye, as this can cause a crowding of the angle and precipitation of angle closure glaucoma. What are the varieties of hypermetropia? So this can be sometimes complex or sometimes confusing, so please concentrate with me what is meant by hypermetropia and what are the different components of hypermetropia. So we all know that atropine is a cycloplegic, meaning that it causes relaxing or relaxation of the ciliary muscle. So since the ciliary muscle are relaxed, this will lead to that the eye will reveal its full hypermetropic error, meaning that if we have a patient or any hypermetropic or any individual, if we put atropine in his eyes, this will relax the ciliary muscle, and the ciliary muscle will has its contracting effect on the lens, and since the lens is now flat and has no contraction or no pressure exerted by the ciliary muscle over it, so it will reveal all hypermetropia. So this will be termed the total hypermetropia, which is the total of the hypermetropia with atropine. So if we wanted to know the full refractive error that the patient has, we put a cycloplegic eye drop, which is called atropine. This hypermetropia or this total hypermetropia is divided into two main components. The first one is called the latent hypermetropia and the manifest hypermetropia. What is the latent hypermetropia? The latent hypermetropia is the hypermetropia caused by the ciliary muscle tone. So every muscle in the body has a tone. So what makes, for your example, what makes your jaw doesn't fall down as you are standing, although it should fall down by the effect of gravity. So your jaw doesn't fall while you are speaking or you are eating because that the muscles of the jaw has half tone, and this tone will keep the muscles or keep the jaw in position without falling. The same thing applies to all muscles of the body and applies also to the ciliary muscle. So the ciliary muscle has a tone, and this tone is present at all states. It is about 1 to 1.5 diopters, and this tone can be only relaxed by the effect of cycloplegic like atropine, cannot be relaxed voluntarily. So you cannot relax your ciliary muscle tone because it is present all the time. So a part of the total hypermetropia will be the latent hypermetropia caused by the ciliary muscle tone, and the remaining part of the total hypermetropia will be called the manifest hypermetropia. So it is the part hypermetropia without atropine. So if this is the part, which is not corrected by the ciliary muscle tone, or it is a part of the total hypermetropia without the ciliary muscle tone. This manifest hypermetropia will be further subdivided into the facultative hypermetropia and absolute hypermetropia. So what is the facultative hypermetropia? This is the part that becomes compensated by the patient accommodation. So for example, if the patient has 4 diopters of accommodation, he can correct 4 diopters of his manifest hypermetropia. And in this condition, this is called facultative hypermetropia. So in this part that the patient will not be symptomatic from. Absolute hypermetropia, this is the part which is not corrected by the hypermetropia. So this part is beyond the limits of accommodation that the patient has, and this is usually what the part that makes the patient complain from defective vision. So if we wanted to change these words into figures, if we mentioned that if we have a patient who has a total put cycloplegic eye drops into the patient eye, and this cycloplegic will reveal the total amount of hypermetropia that the patient has. So it will reveal that the patient has 10 diopters of hypermetropia. So this 10 diopters of hypermetropia are divided into 1 diopter of latent hypermetropia, which is the ciliary muscle tone, and the remaining will be the 9 diopters of manifest hypermetropia. This manifest hypermetropia of 9 diopters are divided into 2 types. The facultative, which is the part of hypermetropia that is not corrected by the patient accommodation, which is +3, for example, and absolute hypermetropia, which is a part is not corrected by the patient's accommodation. So this will be corrected, and this is not corrected. So +6 is the refraction of the patient that makes him complaining of the defective vision. So in case of without using of the atropine, the patient will complain from this refractive error. So again, the manifest hypermetropia is the hypermetropia without the correction of the ciliary muscle tone, and this can be divided into facultative hypermetropia, which is the part that is corrected by the accommodation and the part which is not corrected by the accommodation. So please note that the manifest hypermetropia is the hypermetropia which is present without atropine. So the atropine will cause relaxation of the ciliary muscle. So when we relax the ciliary muscle, this +3 diopter will not be corrected if we are not using the atropine, meaning that in the patient, if we are without using the cycloplegic, he can correct this +3. He can correct this +3 without the use of atropine, but again, without atropine, he cannot correct this +9, but because he doesn't, or +6 because he doesn't have accommodation. Again, the +9 diopters or the manifest hypermetropia is the hypermetropia without atropine. So you may be confused total hypermetropia with atropine. How can be the manifest hypermetropia without atropine? This is after making or after knowing the full refractive error of the patient under atropine. So he has plus 10. This +10 if the patient is non-atropinized or does not have any cycloplegic eye drops, this +9 have two main components. We cannot see the +9 while the patient doesn't have any atropine, because this +9 the only part that we can see is the +6, because this is the part which is called absolute hypermetropia, which is not corrected by accommodation. But we cannot know that this patient has a +9 except after putting atropine, because now we can reveal that the patient has a facultative hypermetropia of +3. So, for example, let's make it a practical example. If you put the patient on the autoref, and the autoref now reveals that the patient has +6. So this +6 is the absolute, that this part which is not corrected by the atropine or not corrected by the accommodation. Now, when you put the patient atropine, you put atropine, the total refractive error is now showed up to be +10. So what is the breakdown of this +10? 1 will be the latent hypermetropia, so the remaining will be 9. And since there is 6 diopter that appeared before the atropinization, then 9 minus 6 will be equal +3. So we will know that this patient was exerting +3 diopters of accommodation. So is this concept clear? So these figures are not fixed. These are variable according to the patient age and the patient state of accommodation. It is fixed. So the latent squint is around 1 to 1.5 diopters. Yes, the absolute is what is apparent on the autoref, or it is apparent while refracting the patient. Yes, that's right. So we measure the absolute first. Then after putting atropine, we know the total hypermetropia, and by subtracting the latent hypermetropia, we can know the total manifest, which by subtracting the absolute, we can know the facultative. So yes, as you can say, as you said it clearly. So what happens with age? What happens in accommodation with age? As you can guess, that in children, all hypermetropia is facultative. So all hypermetropia in children can be corrected by accommodation, since that the children have small eyes and they have a strong accommodation. As we get older, the accommodation become weak, so that part of the accommodation becomes absolute. So here we start to complain. In older age, all hypermetropia becomes absolute, meaning that after 40, as you know, in case of at the age of 40, the power of accommodation or the dioptric power of lens will become only +4 diopters. As we get about 60 or 65 years old, the dioptric power become +1 diopters. As we get older, like 70 or 75 years old, there is no power of the lens at all. So there is no accommodation, so all the facultative become absolute. And here we start, or here the patient start to complain from defective vision for distance, because even though the patient was complaining from the near vision initially, but as the accommodation gets weaker, he started to complain from distance also, as all accommodation or all hypermetropia become absolute, so that he cannot see it as well. Angle alpha, it changes that occur in the angle alpha. As we said, the angle alpha is becoming more than 5 diopters, so that the macula becoming more temporal, more towards the temporal side, leading to increasing or large angle alpha between the optical axis and the visual axis, so that the eye appears to have a divergent squint. However, it has, although it has an apparent divergent squint, but it can have a true convergent squint. So here we have this child. Child has large hypermetropia, and this large hypermetropia made the near vision unclear. And in order to make the near vision clear, this child increase his accommodation. And while the child is increasing his accommodation, this will stimulate the near reflex, which is convergence, accommodation, and meiosis. These are the near reflex triad. So the child makes convergence with his accommodation involuntarily. And as you can see here, when we put glasses in front of his eyes, you can see that the eye are aligned in the primary position. And why is this? Because we correct the accommodation. So when we correct the accommodation, the eye will correct as well, or the convergence will occur, will correct as well. So excess accommodation in case of hypermetropia will lead to excess convergence, leading to convergent squint. Let's come to the optical principle of hypermetropia and how can we correct the hypermetropia. It will be the same principle. How can we correct any ametropia? By first locating the far point or the punctum remotum, then putting a lens in which the focal point of this lens will be coincident with the punctum remotum. So in hypermetropia, we have the light rays emerging from a point on the retina will leave the eye divergent, because either the eye is too short or the optical system is too weak. So how can we correct it? By putting a lens in which the focal length of this lens will coincide with the punctum remotum. So this should be the focal f2 of the lens, from the punctum remotum to the spectacle plane. If we put a lens or a correcting lens in front of the eye in which the focal length of this lens will be the same as the distance of the punctum remotum, then this lens will cause the light rays to enter convergent and to converge these divergent rays in order to allow it to be placed on a focus on the retina. So we use a convex lens with its focal point coinciding with the far point of the hypermetropic eye. This lens will deviate the incident parallel rays so that it will appear to be convergent. Therefore, the light can be brought to a focus on the retina. So as you can see here, this is the hypermetropia. Sometimes it's termed hyperopia. When the hyperopic patient see a target, this target will be placed in a point behind the retina, because either the eye is too short or the optical system is too weak. So how can we correct it? By placing a convex lens. This convex lens will cause more convergent, so it can be considered as an aid. It can aid the eye in order to converge the light rays to place it in a focus over the retina. The focal length of this lens will be equal to the punctum remotum of the eye, or the focal point, the f2 of this lens will be coinciding with the punctum remotum of the eye. So what are the how to calculate the power of the correcting lens? They will be the same principles. So if the correcting lens is present at the principal plane of the eye, then the power of this correcting lens will be equal to 1 divided by the focal length. However, we don't put the lens or the spectacle in the principal plane, which is 15 millimeters, but we put it on 13 millimeters, or what's called the spectacle plane. So we don't put it here, but we put it here at a closer distance to the eye. So we need to compensate for this working distance by taking into consideration the D, or what's called the back vertex distance. So if the correcting lens is placed at the spectacle plane at the 13 millimeters in front of the principal plane of the eye, then the power of this lens will be equal 1 divided by f, which is the focal length of the lens, minus the back vertex distance, and we agreed that in such condition the back vertex distance will be negative. So let's have an example. If we have an hypermetrope which has plus 5 diopters, so the focal length of this lens will be 100 divided by 5, which will be 20 centimeters or 0.2 meters. And this will be, as we agreed, that this is the formula, or we always use the metric form in case of calculation of the power or the focal length. And the D, which is the back vertex distance, it's a fixed number. It is minus 13 millimeter, so it will be minus 0.013 meter. So in order to calculate the power of the correcting convex lens in case of glasses, so it will be 1 divided by F minus D. So it will be 1 divided of 0.2 in the plus form, because this is a plus lens, minus 0.030, it will be equal plus 3.75. So although the patient has an actual error of plus 5 diopters, the correcting lens will be plus 3.75, which will be less than the actual refractive error. This will be the reverse of the myopia. So the power of the correcting convex lens in hypermetropia held in a spectacle position at the 13 millimeters is less than the actual refractive power of the eye. So what happens if we have substitute the corrective glasses with a corrective contact lens? If we want to change from glasses to contact lens, then we use this formula, which is the power of the contact lens equals the power of the spectacle divided over 1 minus the or the back vertex distance multiplied by the power of the glasses. So if we have the power of the lens and the back focal length of the lens, then the back vertex distance, we can calculate the power of the contact lens. So sometimes when you are using glasses, or your patient asks you for a contact lens prescription, you just give him the glasses prescription. And when you give him the glasses prescription, the optician will use this prescription, which is the power of the spectacle, in order to calculate the power of the contact lens. So, and as we said, that the power of the contact lens here in such condition will be positive, because it will, when we are changing from the plus lens or the spectacle to the contact lens will be placed in front of the cornea. So in such a condition, we are moving from left to right, and this will be the same direction of light rays. So just to summarize some practical points, if we have a correcting lens present in the F1, which is 15 millimeters in front of the eye, then the retinal image size unchanged. Again, if we have the, let's say again, the Knapp's rule again and again, the retinal image size is unchanged if we have an axially ametropic eye. But if we have, but this is uncorrected. So if we have an axially ametropic eye and this eye is not corrected, then the retinal image size will be the same as the ametropic eye. But if we have the eye is corrected, so if we place a glasses in the focal length in the F1 of the eye, then the retinal image size again will remain unchanged. But the changes occur if we place if the eye is not axially ametropic, or if the eye is corrected by a lens that is present either away or more inside the F1. So if the correcting lens in the plus lens is present inside the F1 or further than the F1, the retinal image size will increase. This is in case of plus lens. And if the correcting lens is present inside f1, the retinal image size will be decreased. So although the myopia will tend to push his glasses toward his eyes in order to gain a magnifying effect, the hypermetrope tend to push his glasses down his nose in order to gain a magnified effect. So the minus lens causes magnification when it is pushed toward the eye, while the plus lens tend to increase the magnification while it is pushed away from the eye. So this is again one of the common areas in questions in the MCQs. Spectacle magnification. If we wanted to know what is the magnification of the spectacle, what will be the effect of the spectacle on the magnification? So it can be calculated by the corrected ametropic image size divided by the uncorrected ametropic image size. So if we want to know if how much this spectacle causes magnification, just put the spectacle in front of the eye, which is ametropic, and calculate the image size, and then remove this spectacle and calculate the uncorrected image size. So as we said, the hypermetropic cause size. So remember this arrow, the small arrow, the hypermetropic eye, since it is weak eye, it causes smaller image size as it is uncorrected. So if we want to know how much is a spectacle cause magnification, just divide or calculate the amount of magnification of the image size with the glasses divided over the image size without the glasses. But if we want to know what's called RSM, or relative spectacle magnification, then we divide the corrected ametropic image size on the emmetropic image size. So we are not comparing the same patient with and without a spectacle, which will be the absolute spectacle magnification, but we compare the patient with a spectacle to a normal individual. So if the patient has, for example, plus 10 diopters, and this plus 10 diopters can cause changes in the image size, how could this image size will be different from a normal person? And this will be the relative spectacle magnification, and this what will be discussed in more details in the second lecture in the aphakia, when the patient is wearing a high plus lens like plus 10 or plus 20 diopters. Thank you very much for your attention. This is the end of the first lecture. We will take a break about 10 to 15 minutes. Then we will be back for the next part, or the second lecture, which will be about the ametropia.